All right, I think we're going to go ahead and get started. Thanks everyone for being here. This is our 2022 back to school webinar that we are so excited to host again with the GLEAN group. And so thank you so much for being here. Yet last year was a huge success, and so we appreciate the collaboration again this year. We've got a pretty exciting lineup today. We're going to be talking about 504 and IEPs. What's the difference? Why do you need them? And how do you go about getting one if you haven't done it before? We're going to get a COVID-19 update from our specialist, Dr. Downs. And then we're also going to talk about the topic everyone wants to always hear about, and that's diet and nutrition and going back to school. So tips and tricks, how to make it seamless going back to school, and hopefully giving you some good tips for getting your kidney kid off to the right start going back to school. So with that, I think what we'll do is we're just going to go ahead and do some introductions. If you don't know me, my name is Kristen Hood. I am the Executive Director for Research Engagement at NephCure, Kidney International. I'm a nurse, and I'm also a mom of a child who has nephrotic syndrome. So this webinar is always so helpful for me every year to listen to these experts talk to us. So I appreciate the opportunity. And Kelly, do you want to introduce yourself?
Hi, everyone. I'm Kelly Helm. I'm the Executive Director for Patient Engagement for NephCure. And like Kristen, I'm also a parent. I have a 16-year-old daughter with FSGS, and look forward to this back to school webinar every year. So thanks for joining us. And I'll pass to Angela Young.
Hi guys, I'm Angela Young, and I'm a dietitian at Seattle Children's working with nephrology kiddos, and I'm excited to be here. Pass the baton to Linda.
Hi, my name is Lynn Casper. I am one of the school teachers at St. Louis Children's Hospital, where I have worked for a decade now, but I've been teaching for about 20 years. And while I work with all of our hospitalized and outpatient populations, one of my specialty areas is all of our kids with kidney disease. And so they take up a lot of my time, and I have been doing all of these school meetings for the last 3 weeks nonstop. So I hopefully will have good tips and tricks for you. Who wants to go next? Nobody's
Dr.
jumping.
Downs? Yeah, Dr. Downs, go ahead.
Sure, I can go next. Hi, everybody. I'm Kevin Downs. I'm an infectious disease physician at the Children's Hospital of Philadelphia. I take care of a lot of kids with immunocompromising conditions, as well as other conditions. And so I'm going to talk a little bit about COVID and where we are in the pandemic.
I'll go next. I'm Michelle Denberg. I'm a pediatric nephrologist at Children's Hospital of Philadelphia, and have been leading the GLEAN network for a number of years now, and excited to be here. I will pass it to Joseph.
Hi, I'm Joseph Flynn. I am a nephrologist at Seattle Children's Hospital and part of GLEAN, and I am sort of on call, but signing out as I am on the webinar, but happy to be here and hope to be able to answer some questions. And then I'll pass it on to Dr. Laskin.
I'm Ben Laskin. I'm one of the nephrologists at the Children's Hospital of Philadelphia. I also work with Dr. Denberg on GLEAN, and have worked with Michelle and Kevin and Dr. Flynn for many years. So I'm excited to be here, and happy to answer any questions you all might have.
This is great. Thanks so much. So as I said in our intro, we're going to hear from our 3 speakers first. We're going to start off with our teacher, our expert teacher in 504 and IEPs, Linda Casper. And then we'll move into Dr. Downs' presentation, and then we're going to finish with the very important diet and nutrition piece as well. And from there, we'll open it up to a panel discussion. So at this time, I'm going to go ahead and share my screen, and Linda, I'll let you take it from there once I get this up.
All right, awesome. So hopefully the words 504 and IEP are not brand new knowledge to you guys, but I'm going to try to keep this pretty simple, and I apologize if you know all of this already. But in general, any of your kids with these diagnoses will qualify for one or the other. And so I'm going to give you a real quick rundown of how you get one, why it's a good idea to get one, and kind of how to troubleshoot some common pitfalls that come up. So the main thing is that I hear from parents is, well, the school's telling me I need this, or they come up with a whole nother thing that is like a health plan. And they tell us we don't need any of these educational plans. So in general, the 504 plan will fit all of your kids with any of these diagnoses because they have a medical disability, and that is automatically going to qualify them. A 504 is designed to remove any of the barriers that your child is going to face to get their schooling because of their kidney disease. An IEP, on the other hand, is going to do all of those same accommodations, but it will also address any learning difficulties or changes in what your child needs to learn. So not just where they're going to sit, what's going to happen when they can't attend school, or what needs to happen because of certain medications, but it's going to impact their actual learning. They are not going to learn the same amount of material in a given year, or they may learn a different list of curriculum pieces. And the other big difference with the 504 is it identifies every single thing that will be done differently for your child throughout the year, but there won't be goals attached to it. There will be no data tracking, unlike the IEP, where every single need your child has will be tacked on to a specific goal, and every quarter there will be data tracking and note keeping and making sure that progress is being made. And so they look very, very different on paper, but how it looks in the classroom is very, very similar. Next slide, please. So when we're talking about 504 accommodations, think of that as the how, the physical things that need to be different so that your child can access school without any interruptions because of their diagnosis. So one of the biggest things that I always make sure I advocate for is staff training, and that should happen every single school year, regardless of how many years you guys have been doing this. A few weeks before school starts, you should talk to your school staff, remind them, hey, we need to set that meeting, and make sure that whoever is the point person at your child's school for their 504 plan has a sit down in person, now that we can do that, meeting with all of the different professionals who will be interacting with your child during the day, and go over their diagnosis, what that means in the classroom, outside of the classroom, and what each of their individual responsibilities will be for making sure that your child is not only safe, but thriving. It will also, the other big important piece is that it will have an attendance plan written into it. So it will have a plan already spelled out that explains that there will be no penalties for absences that are tied to your child's diagnosis, whether that is for days being out for illness or days being out because of doctor's appointments or anything in between. And then it can have a whole lot of other accommodations built in, such as extended time for responses due to fatigue or nurse visits, whatever that might be. Obviously, having it built in so that there are no penalties for needing to use the restroom frequently or needing to go to the nurse frequently, or having a nurse check in on things regularly. And then also identifying who in the building is going to be your eyes and ears, like on the ground, about dietary restrictions, fluid supports, making sure that, especially for our younger ones or our older ones who are more stubborn, there are other adults looking out for those things. A big piece is homebound planning. Hopefully your child won't require that, but if they do, it's much better to have that written into the plan ahead of time, so the second it is needed, you're not scrambling trying to make up for lost time. It falls into place right when you need it. And we can do some Q&A later about homebound if that is of interest to you guys. An adjusted class schedule has been another accommodation recently that has been really helpful as all of our patients are returning to the classroom in person. We're finding that changing so that their core classes happen in the morning has been really helpful so that they can leave for appointments in the afternoon as needed, or if they have appointments all morning, they can have their core classes in the afternoon. Just minimizing that absence, given that our kids have had so many years of interrupted schooling. Anyway, we want to just maximize the in-person learning every chance we can. PE alternatives are a big one for a couple of my kids, not too many, but it's always something that can be talked about and it should not be off the table as a conversation. And then also field trip considerations, especially with those dietary restrictions, fluid restrictions, things like that. It's often forgotten until the night before the field trip, and then families either feel very anxious about letting their child go, or the school feels anxious about letting the child go. So that is also something that should be in a 504 plan, so that in the regular school year, while their child's in charge of learning their material, they're not also worrying about asking their parents about their plan. Can we move to the next slide? And then you'll notice things look a little bit different in an IEP. You will see all the same things you see in a 504, but you will also see additional things that you will not find in a 504, such as reducing the content of a course or the difficulty level of assignments. And that is something because we're changing what we're asking the child to learn. That is what makes it an IEP accommodation versus a 504. If they require specialized instruction, if they need a special education teacher to do their teaching, that also is an IEP topic, not a 504 topic. Alternative placement can be on both lists. That's where this gets really tricky, is so many of these things can be on both lists. But alternative placement can mean alternative placement in the classroom. It can mean alternative placement in the school, or it can even mean alternative placement in a different school within the district. I get a lot of requests about exemptions from testing or alternative options for testing. And that is a case-by-case basis. The test makes the difference, the child makes the difference, the time of year makes the difference, but it certainly should be part of the conversation when you have these meetings. So you're not scrambling for a plan. Like I said with the field trips, like the night before a test is not the time to ask about that. We often find that we do things like eliminating a penalty for simple things like the grammar or a spelling when it's not a language arts assignment, for example. Because I know a lot of our kids with these diagnoses also do have their short-term memory affected. Maybe not permanently, but while all of this is going on, that is something that comes up pretty frequently when we do testing of these children. And so asking for the focus of their educational time to be spent on the topic for each subject rather than all the extra stuff that goes in the background of that subject really helps our kids learn what they need to learn in the correct time frame. And then doing simple things like reducing the answer choices. So on a multiple choice test, they may have 2 choices instead of 4 choices. And that just helps us really focus their efforts on what they need to be learning. Next slide. A couple of interesting differences that a lot of people don't know and that actually have a lot of weight once you understand why. A 504 plan is different from an IEP in that it goes with you to college. So sometimes you might think that a school is really supportive and they've got very personalized plans with you. And so they tell you, oh, we actually don't need to write that down. It doesn't need to be a 504 plan. But one really important thing to know is if you have a 504 in place and you can demonstrate that it has actually helped your child succeed, that goes with them when they go to a higher learning institution, and the college has to follow that same 504. And so kind of having that background and bringing it with you gives a little more weight to it when you get to the college level. An IEP ends as soon as you graduate from high school, whatever age you do that at. Colleges will have other plans that you can put in place if you have had an IEP, but it's good just to know that going in, because the timing of when you get these plans also may factor into which one they choose for you or which one they recommend for you. A 504 will require a medical diagnosis, and an IEP requires this fun little thing they call an educational diagnosis. So you also probably have the medical diagnosis, but the school will have to give you an educational diagnosis that explains, that puts a learning label on what that medical diagnosis is doing in the classroom. So don't be afraid of it. It's not a bad thing. It just means that that educational diagnosis is what will trigger a special education plan, a teacher or something like that. And then here's the one thing that took me a while of working in the public schools till it actually clicked, and I understood why schools sometimes, when we have a child who's right on that cusp of maybe they do require an IEP, maybe it's a 504, we're not really sure where they fall, and it kind of could go either way. Schools will often ask for you to go the IEP. They will strongly recommend the IEP route, not because your child needs more or less, but because schools get funding for students with IEPs. And so it helps the school provide all of those supports. It's not that they're trying to get money out of anybody. It's just, it helps support the cost of doing what's right for your child. And students with 504s don't get extra reimbursement. And so a school may push you toward an IEP. Don't be afraid of that. They're doing it because they want to be able to afford the right supports for your child. Yeah, I don't want to give you too much information until I know what you really want to know. I'll keep it pretty brief because I know the following presentations are very, very important as well, but I will stick around and answer any question you might have for me at the end.
Hi, Linda. I'm going to touch base on the poll here. And thank you for those of you who participated. We had about 50% or 55% of folks say that the hardest part about a 504 IEP for them is having to explain their child's disease to the school administrators. Do you have any suggestions on the best way to do that? And then
Yes.
a follow-up
Yes.
to that question is, where do they even start to begin to talk to the school administrators to get a 504 or an IEP?
Yeah, and so that's really what one of my main roles is in my job at Children's. Is I act as that liaison in between our families and the schools. And so the families give me permission, I contact school, I speak with the school counselor is usually the very best place to start. Every school will operate a little bit differently as to where it goes from that point, but the counselor is kind of the gatekeeper of that. And they will loop in the school nurse, they will loop in the dietitian, they will loop in sometimes in these smaller districts, it's the principal. But hopefully all of you guys have connections to some kind of hospital setting and the child life specialists that go along with that. If you have that person, reach out to them, ask for diagnosis education that's at the kid level, because we have found that when we give schools all the information at our medical professional level, they try to understand it and they understand it to some degree. But when we give them the materials that we write for kids to explain to the kids and for kids to explain to other kids, it lands a little bit better at the school level as well, because it gives those teachers and those counselors the talking points that really do matter. And so, if your child has received an education book that says like how to talk to my friends about my disease, make a copy for the teacher. If your child feels comfortable, especially in those lower grades, ask for the school to have a time at the first couple weeks of school where either you or your child's child life specialist, whoever that might be, come in and do a read aloud, do a little education session in the classroom. We've had some real good success working with the dietitians at the school, and they put together whole nutrition presentations where they touch on it enough that they don't draw too much attention to the one child, but they bring it up enough that the kids all are like, oh, wait a minute, that clicks a little bit, I get it now. Or in health class in those 4th, 5th grade years, and then obviously middle school and high school, we try to build that in and let the patient be the one to take ownership over what they want to share, how they want to share it, how involved they want to be. But that buy-in is huge, and having your child's teacher or counselor or nurse really feel like they're on the team goes a long way. Invite them to call your team at the hospital. Like, invite them to come in and visit for a morning, whatever that might be. When the team at the school feels connected and feels like you want them to be part of the regular team of your child's life, they tend to be a little more receptive and responsible for it.
Yeah, that's great. I will say that if you are interested at NephCure.org, on our website, depending on your child's kidney diagnosis, obviously we focus our support and educational efforts around rare protein spilling kidney diseases. But if you go to NephCure.org and you look at the diagnoses, there are some printable sheets along with your diagnosis. So if your child has FSGS, or if your child has minimal change disease, or if your child has, IgA nephropathy, whatever your disease is, there is a sheet that you can download. I would tell you to download and print some of those off, just like Linda was saying. When my child was diagnosed, I think one of the best people to get on board is your school nurse. Your school nurse may not have a whole lot of information on your child's kidney disease. But if you go to that person and get them to understand the disease, you've got someone that's going to rally right with you and understand a lot of those medical and nursing needs that your child requires that relate to how you want the administration and the teachers to respond for the 504 or IEP planning. So Linda, that was great. And to start off, if their school, if they've never done a 504 or an IEP and they want to know and get one started, would they go to like the principal? Would they try to contact the counselor? Who would you recommend?
I would recommend the counselor. But if that is not either comfortable for you or you don't get response right away, go to the assistant principal or the principal. Once you have made that official request, it starts a clock for them, and they have a timeline of when they have to respond, even if they end up ultimately declining, which they won't. They just won't. But there are strict timelines of when they have to have certain responses from the time that you officially make that request. So even if you send them an email, like the timestamp on your email is when that starts.
We do have one more question. That's actually a really good question, Linda, and that is, are 504 and IEP plans only for public schools?
That's a tough one. There's a lot of nuance to that, but the short answer is yes, because it is publicly funded, it is all of that. But private schools often, well, all the private schools will also have that. Each one has their own name for what it might be, but basically it's a health plan. And so if you really want to remain in your private setting and you're having a hard time getting support with that, I would definitely reach out to your medical team. Somebody there can come back with you and provide a little more weight, or even get a copy of someone else's 504 or IEP that's working really well at a different school and give them that. They want to do the right thing. They sometimes are just very afraid of doing the wrong thing. And so coming at them with somebody else, like especially within this group, if there's anyone who feels comfortable sharing their plan that they think works well, it's a template. It's like 100 different boxes you get to check. And so if you show which ones you checked that worked well, it's a good starting point that private schools can follow.
Yeah.
If your child requires more assistance, like within an IEP, so they might need speech, they might need OT, things like that. Your public school where you live, even if you don't attend there, in most cases will have to provide some of those services for you anyway. But there's a lot of hoops you'll jump through to do that, and you'll have to then take them typically to the public school at the end of the day to receive those services. But it's not out of the question.
Yeah. Kelly had put in the chat a link. We do have a page on our website that gives some information that will support Linda's talk today around 504. There's even a template about a letter. So if you've never had a 504 before, and you want to start that process, You can download that template to use as a starting point if your physician doesn't already have one. Most of the doctors, especially the ones that are here with us today, are well versed in some of these forms and are used to doing it. So, but it's a good starting point. The other resource I was going to mention, besides printing off the disease sheet that can explain your child's kidney disease to your teacher or to the school nurse, would be this Nephrotic Syndrome umbrella one sheet that we also have. And we can put these in the chat, later on, or we can follow up in our follow-up email. We can put them in the follow-up email to everyone as well. It's a good overview of what nephrotic syndrome is. And it also delineates some of those diseases that encompass the nephrotic diseases that happen when you have nephrotic syndrome. So Linda, thank you so much. Stick around. I'm sure we're going to probably have some more questions for you, but right now I'm going to turn it over to Dr. Downs, and Dr. Downs, I'll let you take it and you can share your screen.
All right, great. Thank you. All right, so we're going to talk a little bit about COVID, in case you haven't heard of COVID. It is still around and we are still dealing with it, but we're in a slightly different place now. So an update as we head into the fall. You'll notice that there's going to provide a little bit of data and just generally talking a little bit about vaccines and sort of some newer changes from the CDC. But here's the most recent map of cases of COVID in the United States. It's worthwhile noting that over the course of this, the last few years, the definitions have changed a little bit, but you can see that where we are now on the far right-hand side, it is in a good place in terms of overall cases compared to, say, where we were in early January when the Omicron variant hit us and we were really seeing a lot of cases. What's sort of highlighted here in the yellow are cases 5 to 11 years of age. The pediatric cases remain to be fewer than adult cases. Here is a slide that's showing on average the number of deaths that are occurring from COVID, and similar to January, we are in a much, much better place. Fortunately, in pediatrics, as you can see by the yellow line that's there all along the bottom, children have done remarkably well with this virus since its onset a couple of years ago. Even though infections are occurring, severe infections and deaths are very rare in children and remain so. This is what our current map looks like in terms of community transmission, where red is high transmission, and that's defined based on the number of new COVID hospitalizations, as well as how many, what percentage of inpatient beds are used by COVID patients. So the red being higher areas of transmission, yellow being medium, and green being low transmission. And this is a good map to look at. I think it just lets you kind of know regionally there are differences. We see some hotspots in the southeastern United States, but comparatively, I would say at this time last year, we were seeing a lot more red, and fortunately, as we head into school, we're seeing more green and yellow. And this is, I find, a very useful map, particularly for parents of patients who are immunocompromised, in that it's hard to get information and real information about sort of what's going on in your community. And this is a really useful map to look at. It narrows it down to the county level. And so you can get a sense of what's going on in your community, which is informative as you're making decisions about sending your child back to school. And as you've likely heard, we've been dealing with the Omicron variant since early January. This has been the dominant variant in the United States since January of 2022. And currently the BA.5 strain is the most common subvariant that we're dealing with, but it's all still this Omicron variant. And as unfortunately where we are currently with the virus is that we're now in a situation in which the virus has become endemic, meaning that it's not going to go away. We're likely going to see sort of waves of it over time as variants occur. And there's nothing to be particularly scared about when it comes to variants. That is how viruses evolve, and over time they change. We see it happen with every type of virus, and COVID or SARS-CoV-2 happens to be the same. And so with time, we're going to see some variants that change. We might see infections that come and go. And unfortunately, this is going to be something that we're dealing with for quite a while. The good news is that even though the current strain of the virus, the BA.5, causes more infections, those infections have been less severe. And we hope that that will be the case for future variants as well, that perhaps we'll be seeing waves of infections, but continue to see fewer and fewer hospitalizations over time, particularly as more patients have immunity from prior infection as well as vaccination. And the vaccines are highly effective. I think we unfortunately suffered a little bit from some messaging or mismessaging early on, in that there was hope, or at least perceived hope, that vaccines were going to end the pandemic, when that was really not a very realistic goal for vaccination against this virus, because respiratory viruses infect your nasal passages and spread into your lungs. It's really difficult to develop a vaccine that's going to prevent a virus from infecting someone. But what it does do, and what these vaccines do particularly effectively, is prevent people from getting seriously ill and dying. And so vaccines remain highly effective against the current strain of COVID, and we hope that they will in the future. But people are continuing to do research to try and understand what is the most effective vaccination or immunization approach as this virus continues to change over time. Fortunately, unlike when the pandemic began, we do have some therapies that are effective. We have some monoclonal antibodies, some of which are preventative and some of which are treatment. And we have some antivirals that maintain activity against the virus. And so we have a few more tools in our toolkit than we did when this pandemic started. And so I think just to address some specific questions about nephrotic syndrome, a question that comes up is whether children with nephrotic syndrome are at higher risk from COVID-19. And in general, compared to adults, children and adolescents are at lower risk for hospitalization or severe disease with COVID-19. We've seen that throughout the pandemic. It remains to be the case with the current strain of virus. Respiratory viruses can cause severe illness in patients with impaired immune systems, and this is true of both children and adults. And we've seen, relative to their peers, immunocompromised children are at higher risk of getting sick from respiratory viruses, including COVID. But there remains little data regarding the risk of COVID for immunocompromised children compared to adults. Based on everything that we've looked at so far and sort of mounting data, we think that the highest risk groups for severe COVID among children are those receiving high intensity chemotherapy, for instance, patients who have had a recent cancer diagnosis, those who have profound antibody deficiencies or dysfunction, such as severe combined immunodeficiency, a significant inherited immunodeficiency, and those who have very low lymphocyte counts, which are white blood cells that are a particular portion of white blood cells. Those groups tend to be the highest risk groups amongst children that we've identified so far. There are some other comorbidities that may make children at higher risk of more severe infections. Those include things like obesity, underlying lung disease, or underlying cardiac disease. So those are some important comorbidities that also can carry risk. And because those conditions carry risk of more severe respiratory infections with any type of virus. In terms of nephrotic syndrome specifically, there have been some rare reports of relapses of nephrotic syndrome that have been triggered by COVID. In fact, I would say that COVID virus itself can cause flares of underlying disease, whether it be nephrotic syndrome or autoimmune diseases. So COVID, has acted very differently than some other viruses. But children with nephrotic syndrome, either with or without immunosuppression, do not appear to be at higher risk of contracting COVID-19 or developing severe COVID-19. And that was based on a report published late last year. And based on Omicron, we have not seen that to be different. So we do want you to try to be protective against COVID-19 in your child with nephrotic syndrome, but the biggest risk may be for potential relapse of your underlying disease as opposed to developing severe COVID. Importantly, it's with vaccines, there's been a lot of information and misinformation about the COVID vaccines. And an important one to ask is whether it's safe for your child to receive COVID-19 vaccines. The good thing is that we have a lot of data that has been developed over the last year plus since the vaccines were first available on the safety of COVID-19 vaccines in children and in adolescents. And we have, although there's not a lot of data in the nephrotic syndrome population specifically, we have not seen any significant signal that COVID-19 vaccines trigger nephrotic syndrome relapses, or that they are associated with any specific side effects. And in fact, far fewer case reports have been published about nephrotic syndrome relapses following COVID vaccination compared to the disease itself. So the benefit of COVID vaccination appears to outweigh the risks in the nephrotic syndrome population, but it's important to always talk with your doctors about the timing of vaccinations in relation to your child's medical treatments. Are COVID-19 vaccines effective in children with nephrotic syndrome or those who are on immunosuppressive medications? This is an important consideration because we know that immunosuppressive medications, although they're designed to treat the underlying disease, can also decrease someone's response to an immunization. Despite this, we recommend COVID vaccination in all eligible patients 6 months of age or older, regardless of their immune status. We just have to be cognizant or aware of what the timing of vaccination should be. There may be a window in which your child's more likely to respond to the vaccination, and so that's the ideal time to vaccinate. But we do not see any concerns in terms of risk about giving the COVID vaccines when someone's on immunosuppressive medications. You can't contract COVID from the vaccine. It just may not work as well if your child's on immunosuppressive medications. So talk to your doctor about the right timing of the vaccines if your child's yet to be vaccinated. Just to clarify, because I know there's been a lot of confusion and, unfortunately, some of the messaging around booster doses make it seem like the vaccine's really not effective. But I think what we've learned over time is that for some children and some adults, 3 doses really is the most appropriate regimen. So it's not that we're continuously boosting vaccines. It's just that in order to mount an adequate and durable response, someone might need more than just 2 doses of an mRNA vaccine. So the primary series, what that is defining is really what should the initial vaccination strategy be to provide protection. In someone who is not immune compromised, that's 6 months to 4 years of age, if you're receiving the Pfizer vaccine, that would be a 3-dose series. If you're 5 to 17 years old and receiving Pfizer, that would be 2 doses. And from the Moderna vaccine, it's a 2-dose series regardless of age. When we talk about booster doses, now what we're talking about is receiving an additional dose on top of that primary series to maintain adequate immunity over time. And this too varies based on what the initial vaccine was that your child received and the child's age. For instance, if your child is 5 years of age and older and received the Pfizer vaccine, they would be recommended to get a single booster 5 months after their initial series of 2 doses. If your child is 12 years of age or older and is immunocompromised, they might be eligible for receiving 2 boosters in order to fully maintain their immune response over time. And so what that looks like for an immunocompromised child, and I know this is kind of a busy slide, but you can see that based on age, the number of doses that are recommended will vary based on not only age, but also the vaccine that's given. A Moderna vaccine is 3 doses regardless of age. The Pfizer BioNTech vaccine is going to vary based on what your child's specific age is. And unfortunately, as we head into the fall and time goes on, we're likely to see the recommendations change in terms of the timing of vaccination, the timing of booster doses. It may be something that's required annually as variants change, as immunity wanes over time, and don't see that as being an indictment of how the vaccines work. We know that immunity goes down over time, and as the virus continues to change over time, we might need to give some extra boost to our immune systems. So unfortunately, it's hard to predict how that's going to play out. but certainly, continue to speak with your doctor and see how things will change. Should you be taking any special precautions this fall as your child heads back to school? Nothing new in regards to what works against preventing COVID and other respiratory viruses. Hand hygiene, washing hands often is important. I think the most important message that we're moving towards is staying home when sick. So and we'll talk about this in just a second, we're moving a little bit out of this pandemic phase where we're talking about quarantine and COVID being an emergency, and a little bit more to trying to mitigate infections by people staying home. So it's really more about people with COVID staying home than it is about trying to stay home when you might have been exposed. A mask continues to remain an important and effective way to prevent respiratory infections, including COVID. It's not perfect, but it helps. And particularly if you're in a public setting or closed space or around a lot of people, a well-fitting mask is going to be beneficial and decrease the risk. It's not going to eliminate the risk, particularly when others aren't wearing masks, but it's going to decrease the risk, and every little bit counts. And so, that's the general strategy as we head back to school this fall. We are going to see some changes. We've just seen some new guidance from the CDC regarding COVID management, COVID prevention, and they have released some new guidance for schools in particular. And I'm sorry I didn't put the link on here, but if you type CDC and guidance for schools into Google, it will take you right to this website. You can see what's new. But the big changes are that they've recommended recommendations to cohort. I think a lot of schools were trying to keep groups together, keep like smaller classes together. That recommendation's gone. They're no longer recommending routine screening in schools, only for potentially high-risk activities such as sports where people are in very close contact indoors for a prolonged period of time. And they've removed the recommendation to quarantine. So quarantining is when you stay home when you've been exposed, if you're an unvaccinated individual, or the test to stay policy where you would test, and if you're negative, you could stay in school. Those policies have been removed. So now isolation continues to be recommended, where someone will stay home if they're sick or they have COVID, if they're symptomatic. And so it's really moving to try and test people with symptoms and stay home when you're sick. And then again, masking is recommended when transmission is high in your community. And we should be encouraging people to wear masks for 10 days after a known COVID exposure or COVID infection. So in conclusion, there's still remains no evidence that children with nephrotic syndrome are at higher risk of contracting or developing severe COVID. You still want to take precautions for your child because of they may have a risk of relapse of their underlying disease, as well as they may have some other comorbidities because of the medications that they're on that put them at higher risk. We still want to encourage COVID vaccination for all eligible children and recognize that we're moving to a post-pandemic time about management of this virus. It's going to be around for a very long time, and we're needing to live with it a little bit more. So certainly contact your medical team with any questions. And as always, medical decisions are individual discussions with your medical team.
Thank you, Dr. Down. Sorry, I was muted. I just wanted to touch base on one quick question before we move into the diet and nutrition. It's a great question from Becca. Do you recommend the current booster vaccine prior to starting school or waiting for a more current variant targeted booster? If so, is there a projected date for the more specific booster?
Yeah, so it's a really good question, and I think there's debate on that in both sides. I will say that from what I'm aware of, the evidence supporting variant-specific boosters is not great. I think it makes sense in theory. I think it's at least as effective as the original vaccine, but I don't think that there's data to show that it's superior at this time. So I think if your child is ready and should be boosted based on the schedule, I would suggest doing it sooner rather than later to make sure that they're protected heading into the school year.
Yeah, that's great. Thank you. That's the only question we have right now. I do have to say that on the poll, the questions around COVID, it seems like it was pretty split as far as, people feeling comfortable. Yes, there's been relaxed guidelines or restrictions, within the school systems. But most people feel okay. Some are still a little nervous about their child if they do get COVID. I think that your presentation really honed in on the fact that even if they do get COVID, obviously there's some good data to show that they will fare well and do pretty good through it. And I would say just as also as a nurse, I would say if your child does get COVID and they do have a disease that causes nephrotic syndrome, that's whenever you would probably want to be testing their urine on a daily basis, just watching the protein in their urine until their symptoms are relieved and that sort of thing. So, and then always touch base with your nephrologist. That's always a good thing. So now we're going to move on to Angela Young. And Angela, I'm going to let you go ahead and share your screen.
Great, thanks. Okay, so I will end the presentation here with the nutrition portion. So let's start to dig in just for the sake of time. So I'm going to be talking. So ultimately, diet and nutrition kind of comes into play with helping manage kiddos' symptoms that they're having. So I'm going to talk about sodium, touch on fat, and then talk about nutrition management when kiddos are on steroid therapy. So let's start to dig into start to dig into sodium, sorry. So ultimately, what is sodium and why are we talking about sodium? So sodium is a mineral and it's going to be found in table salt. Also it's found as a preservative in many of our processed foods, packaged foods, frozen foods, canned foods, and foods that we find out to eat at restaurants and fast food is also going to be higher in sodium. And ultimately limiting sodium in our diet is going to help reduce, that fluid retention or edema that we can kind of see during nephrotic syndrome, and can also help to keep our blood pressure normal. So some planning tips just to kind of start out on how we can, eat lower sodium in our diet. We want to eat food in its most natural state when we can. So what I mean by that is, trying to opt for more fresh fruits and vegetables. If we have to opt for canned foods, doing, low to no sodium, maybe washing them off with water. Cooking rice from scratch and then adding low to no salt seasonings with that. Secondly, we want to opt for lower seasoning or lower sodium condiments, or really watch our serving size with condiments because it can add up really fast, our serving sizes for the amount of sodium that it provides. So if your kiddo really likes ketchup, it might be worth opting for like a lower sodium ketchup, or making like a homemade ketchup or homemade salsa or guacamole. And also thinking about limiting like those higher sodium condiments like pickles and olives. And then ultimately, one big thing here is we really want to avoid adding salt to our food, and trying to utilize those fresh herbs and spices, garlic, lemon, lime, when we can to season food, or opting for salt-free seasonings like Mrs. Dash, because about a teaspoon of salt is going to be about 2,300 milligrams of sodium. And that is at 2,300 milligrams of sodium that's found in just a teaspoon of salt. Really is going to be more than we want your kiddo to have in a day in the amount of salt. So really sodium is individualized, you know, by working with a dietitian or your nephrologist. But I would say with, you know, specifically speaking with nephrotic syndrome at Seattle Children's, you know, we typically like to aim for more of the 1,000 milligrams of sodium per day, as much as we can, but it can kind of vary between 1,000 and 2,000 milligrams of sodium in what we want your child to be aiming for throughout the day. And then this bottom graph here just kind of shows that really to kind of set our day up for success, we really want to choose the majority of our food that has less than 140 milligrams of sodium or less to really set our day up for success in meeting that. So I just want to touch on reading the food label because I think this is a good tool for everyone to know how to do. So this food label you'll find on the majority of packaged foods, and it includes, you know, the sodium content here. It includes a lot of other helpful information as well. But it's important first that we want to look at the serving size at the top. And we see that in this specific food, this ketchup bottle, that a serving size is about 1 tablespoon. So for every 1 tablespoon of ketchup that your child would eat, it would provide about 160 milligrams of sodium. And it's really important to note that, you know, if you eat more than 1 serving, so more than 1 tablespoon of ketchup, then your child will be getting more sodium than what's listed on this label. So for instance, if you would have 2 tablespoons of ketchup, which would be 2 servings, you would receive 320 milligrams of sodium. So we can see here that you know, 160 milligrams, or if we would have 2 servings, 320 milligrams, that would put us into the medium to very high sodium category. So it might be worth, in this instance, looking for a low sodium ketchup that has kind of half that amount of sodium. Okay, and then this page just really has some tips and tricks for lower sodium eating. So I'm hoping that, you know, you guys can utilize these resources and kind of these low sodium meal and snack ideas for school lunches or different school snacks that you might be able to send to school with your kids. Okay. Here, secondly, I want to transition to touching on fat, because in nephrotic syndrome, we typically see sometimes the triglycerides and the cholesterol levels elevated. And this slide just gives some tips and tricks on, you know, how we can kind of manage those in our diet. So really opting for healthier oils that are listed here below, using lower fat dairy products can help to lower triglycerides and our lipid levels, and also just cutting off that excess fat off meats or that skin off poultry. It's also worth noting that when you're looking at the sodium on the food label, it's important to look at the saturated and the trans fats as well. So we ideally want these to be 0 grams because these saturated and trans fats will also play into our higher lipid levels. And another way you can kind of note if a product has trans fat is to see if on the ingredients list label, it labels hydrogenated. And if it has a hydrogenated word in the ingredients list, then we kind of want to maybe put that back on the shelf and see if we can find another item that doesn't have that. Okay, and lastly, I just want to touch on, you know, nutritional management of some side effects that we can see from steroids. So ultimately, you know, steroids can cause weakening of the bones, especially around the joints. And this can happen because, you know, steroids cause the body to causes the body to absorb less calcium from foods, and can also speed up the breakdown of our bones. So would really encourage you to talk with a dietitian or ensure that your kid is meeting adequate amount of calcium and vitamin D in their diet. And also encouraging just like regular physical activity as tolerated. So this chart here kind of gives the recommended amount of calcium and vitamin D with children taking steroids, but I would really encourage you, like I said, to have that conversation with your medical team to see if you need that supplementation, maybe get your kids' vitamin D checked and just monitor that. And then also, children on prednisone or steroids might also feel an increased sense of hunger. They can also, it can also cause the amount of sugar and glucose in blood to be higher than normal. So I would say, you know, to manage this in our diet, we can avoid foods that have lots of sugar, such as candy, juice, sugar sweetened sodas, and try to offer healthier meals and snacks that include like fruits and vegetables and that are lower in sodium. And I just put, you know, some ideas for some snacks that you could offer below. And this last page just also provides you guys with some kidney-friendly eating resources. And this second point here that's on says Kitchen Kidney. It's going to have a lot of really great recipes that you can tailor to what your kids' specific needs are. So if it's low sodium, or if you want lower protein or lower phosphorus. So it's a really great resource. And that's it. Thank you, guys.
Thank you, Angela. I just want to touch on our poll really quickly. 50% of those polled would like more information on whether their child can eat the cafeteria school provided lunch. Do you want to break the news?
Yeah, unfortunately, the guidelines out there on how much sodium they have to stay below for school lunch is very high. It can be over, it's like around 1,000 milligrams or around that area. So if you guys are able, I would really encourage you guys to work with your kids on maybe packing their school lunch, because the school lunch can, you know, can add up to, you know, around 75% to 100% of their daily needs.
I want to chime in on that. The whole time you've been presenting, I've been taking little notes about things I wanted to say. The last year, as our kids have been returning in person, I've been working with a lot of our kids. The kids I spend the most time with are our kids who are actively on dialysis, but it applies. So we've worked very closely with the dietitians or the cafeteria managers in various public schools, and we've kind of reframed it so that we make sure that someone from that department is on the child's 504 team, and they have to attend their team meeting, just like the school nurse. And our nutritionist talks at length with them before the meeting, and so we've had really, really strong responses, very positive responses, where they sit down with our nutritionist and they like outline, okay, here's the menu for the next 3 months. Look at it with me, highlight what's good, highlight what's bad. And then they've actually come up with plans almost like they would for a child with a severe food allergy, because that also has to be in a 504. And they treat the dietary restrictions like a child with a food allergy. And so they have it marked on their calendars in the cafeteria. And if it's Tuesday and it's the B lunch, they know that there's a child who has the sodium restriction, and they put out a different batch of choices where they have alternatives. And they do it, especially in the younger grades, they've been able to do it almost so that the whole class gets a similar alternative option, so the child isn't isolated. It doesn't feel like, oh, how come everyone else can have that and I get these carrots or, whatever. But that is one idea that I was just thinking the whole time you were speaking is school lunch is just fraught with anxiety for sure.
Yeah, okay, thank you. So we have some good questions that have come in, and so I'm gonna start. This first one is for Dr. Downs. There's a question that came in that says, what if my child is behind on the booster and is now taking Tacro? Is it still wise to get the vaccine or to get the booster?
Yeah, I would suggest getting the booster in that circumstance. Tacrolimus can have some impact on immune responses, but not as much as some other immunosuppressive medications. So I think the times of really intense immunosuppression are probably not the ideal time to get vaccinated. But if your child's on a stable immunosuppressive dose, then I would move forward with the vaccination.
Great, thank you for that. This next question, I'm going to open it up to our nephrologists that are here with us today. There's a question that came in that says, if my child is undergoing a steroid treatment, should she be kept at home from school? And I'm assuming this is probably if they're on high dose steroids. Let's just go with high dose steroids first. Should the child stay at home? Would one of you like to answer that question?
I'll take that one on. I think, it's, there's a lot of factors that go into that decision, right? Including, what's going on in the school and the community. And, I think if they're just on prednisone and not another immunosuppressive medication, and especially if you're challenged with, being able to keep them home for whatever reason, childcare or that sort of thing, or your own job, then sending them to school may be, okay. I think there was another question in the chat that about a newly diagnosed patient and what do they need to know. And so, you do need to have a conversation with the school teacher about, being informed if anybody has, in the classroom has chickenpox or measles or some other highly communicable disease that can really go be quite dangerous on somebody on full dose prednisone, even if they've been vaccinated. So having a conversation with the teacher, I think, is important. And then, I think probably you can, and especially older kids that have been through it before, I think it's okay. It's the kindergartners and preschoolers where I think it's a little bit more hard to know what to say, and you have to really assess what's going on in the school, what the classroom is like, whether you can work with the teacher or not.
Yeah, I think that's really important. I think it's also important to figure out, the social, mental, and emotional health of your child, and how keeping them home from school, if you choose to do that, could impact that piece of their life as well. I think it's also really important if your child is on steroids, high dose, long term, that sort of thing. This is where the 504 can really help you as far as getting some of those accommodations, maybe some rest breaks, understanding the absences that might go along with some of these, medications, as far as like fatigue, discomfort, with the edema that sometimes gets associated with some of that edema weight from the high dose steroids. And so all of these things are really important to make sure that you have in your 504. If they have pain, or because of the edema with high dose steroids, they might need a little extra time moving from class to class. So maybe they get out of class a little bit early to make it to the next one, or maybe they need to be released a little early before the flood of kids at the end of the day. These are all really important things to really talk about with your administration. Talk to your school nurse And then obviously with the school counselor to get that set up too. I do think though that mental and emotional piece is and social piece is really important to consider. But the health of your child overall is key. So thanks for answering that one, Dr. Flynn. Another question that came in, and I know that we're running a little bit over, but we just have a couple more to answer if we can just stay on. Liz has asked about any suggestions, and maybe Linda or Dr. Denberg, this could go to you. Any suggestions on how to approach the school with the severity of nephrotic syndrome? Her son's school seems to be taking it lightly, and that worries this mom. What would you suggest, Dr. Denberg?
Yeah, I think actually related to what we were talking about and some of the resources that you had mentioned, printing in reference to the 504 plan, I think providing some of those materials to, to take the burden off of you having to explain nephrotic syndrome and the complications and risks, providing some of the either written materials or links to useful sources like NephCure's website, and really giving the educators access to some of that educational information so they can understand, what nephrotic syndrome is and what are the most common complications. And I think just really partnering with the teacher to say, it's a different level of vigilance, both like Dr. Flynn was saying, if there's something going around the classroom, but also if your child is having a fever or complaining of belly pain or headache, that that you want to be informed, because it may be, the evaluation may be different than a child who doesn't have nephrotic syndrome.
Yeah, that's a really great point. And to tag along with that, like Dr. Denberg re-emphasized, there's some resources that you can print out. We also have some videos, around the child's journey with nephrotic syndrome, and you can send those video links from our website to your teacher, or to the school nurse, or even to the principal, whoever you think might benefit from watching, because sometimes they get a lot of paperwork, but maybe they can watch, a few minutes of a video and get more of an understanding of what this nephrotic syndrome can do to a child. And then the processes that we go through as caregivers and caretakers to make sure that they stay as healthy as possible. So that's another resource to look for on our website as well. One last question that we have in our that has come in. Again, this is for our nephrologists here today. One of the parents has asked, if my child with nephrotic syndrome is not under any treatment, so perhaps their disease is, is not active right now, do they need to continue a low sodium diet?
Is Dr. Laskin on? He hasn't had a chance.
Yeah, Dr. Laskin, you want to take this one?
I saw Dr. Flynn shaking his head, so I might get in trouble for saying this. But all patients
We
should
have to
always
give you a chance to talk, Ben.
I don't know if you're going to agree with what I say. So absolutely, if they're in relapse and they're on steroids, we, endorse that they have to be on low salt, because number one, the steroids cause salt retention, and number two, of course, being nephrotic, you'll retain salt and fluid. If you're in remission, I think you can be a little bit more lax. At least that's what I tell families. If they're not on steroids and they have no proteinuria, of course, trying to eat a normal, healthy diet, we would support that. And there is a large obesity epidemic out there outside of nephrotic syndrome. But in general, if kids are being healthy, I think it's fine to have a little extra salt here and there, assuming, again, they're in remission. They won't. Some families actually ask us, will the salt cause a relapse? And there's no evidence for that. I've gotten that question a lot from families. But yes, be important, be healthy, follow Dr. Flynn's recommendations for salt intake and cardiovascular health. But in remission, it's okay to cheat.
Yeah, I have to say, I think sometimes if you follow kind of that lower sodium guidelines that Dr. Laskin is mentioning, even when your child is not in a relapse, if their nephrotic syndrome is kind of latent, If and when they do relapse, it might be a little bit easier, because that transition to restriction may not be as hard. So I have to agree with that. And honestly, we could all do with lower salt in our diet too. So I have to.
Everything in moderation.
Everything in moderation. Yep. And you know what? Some cheat days. If you're not on those high dose steroids and that sort of thing, then or having nephrotic syndrome relapse are okay. But in general, it's a good thing to restrict the sodium when you can. Well, that is it for the time that we've had today. We've gone over, but this has been a really great session. I appreciate everyone for being here with us today. We will follow up with some resources in an email. So everyone that's been here today and that registered will follow up with some resources. And you can always find out more about us at nephcure.org. That's NephCure.org. And again, thanks again for being here with us. And I hope everyone has a wonderful back to school. And from there, we'll see you next time. Thank you, everyone.